Thank you for having me here. And my colleague unfortunately couldn't be here today. It's my pleasure to talk to you about different aspects and talk about systemic therapy or chemotherapy for different types of gynecological cancers. These slides were prepared by Dr. Gigi Chen, and I give all my credit to her for preparing them. Some of these points have already been covered, and so I will skip over some of the discussion points Dr. Paik has already made. So this is a slide that talks about different types of gynecological cancers, where uterine cancer is the most common one that's diagnosed, followed by ovarian and cervical. And these are cancer deaths by different cancer types, where ovarian cancer contains a predominant share of cancer deaths, followed by uterine cancer for reasons that were stated earlier. So who's a cancer survivor? Cancer survivor is generally an individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. However, this is a disease that affects everybody, including family and friends, and family members, friends, and caregivers are also impacted by the survivorship experience and therefore included in this definition. It's not just how you live. It's not just that you live, it's how you live. So the quality of life becomes quite important for patients suffering from this type of condition. I'll briefly talk about cervical cancer. As I mentioned, many of these discussion points have already been made by Dr. Paik, but I'll cover them briefly. It's the third most common gynecological cancer. It's estimated that about 12,000 new cases will be diagnosed, and about 4,000 women will die from cervical cancer. But because of pap smears and screening tests and HPV, hopefully this number will decline over the coming few decades. It was once one of the most common causes of cancer death, but the death rate has declined by 70% between 1955 and 1992 thanks to screening efforts, and hopefully with HPV vaccination this will continue to improve. The average age of diagnosis is 48, and HPV can be detected in almost 99% of patients with cervical cancers. And the subtypes, there's many different types or subtypes of HPV, but the HPV 16 and 18 are found in over 70% of all the cervical cancers. And most of the times, early cervical cancer is asymptomatic, so you wouldn't know it unless somebody gets a pap smear. So, but the common symptoms for cancers that is more advanced would be abnormal vaginal bleeding and vaginal discharge. And it may or may not be visible or palpable on the physical exam, so this requires specialized testing. HPV vaccine, I will, again, won't cover this in much detail. It's developed to prevent infection of some of the HPV subtypes that are associated with cervical cancer, and it produces immunity to those two subtypes, subtypes 16 and 18, but not all the other subtypes of HPV. This is percentage of adolescent girls who receive 3 doses of HPV vaccine, and there's geographic differences across the country in terms of, and in California it looks like it's 25 to 30, almost about 30%. So there needs to be a lot more education about the health benefits of this type of vaccine, and as you can see there's a lot of room for improvement. The states in dark blue are doing a much better job, and the states in yellow tend to be the worst in terms of how many of these adolescent girls are getting vaccinated, and it's down to almost 17% in some of the states in the southeast. A very early stage can be treated with surgery, as Dr. Paik mentioned. However, patients with high-risk features, that hysterectomy, if the margins are positive, if there's lymph node involvement, may benefit from additional treatments such as chemotherapy and radiation. And for reasons stated earlier, for patients who have stages 2 to 4 are generally treated with a combination of chemotherapy and radiation. However, there are some recent advances. Traditionally we use for advanced stage cancers we use chemotherapy, and some of these chemo drugs have been around for decades. But lately there's some more data on using targeted drugs. These are medications that are not necessarily chemotherapy, but they're biological treatments or antibody-based treatments. And one such drug is called bevacizumab, or Avastin, which is also used for other cancers besides cervical cancer, including lung cancer, brain tumors, etc. And what this drug does, it helps block the formation of new blood vessels. So somehow the tumors need nutrients to grow, and there's a formation of abnormal blood vessels that feed the cancer. What this drug does, it stops formation of abnormal blood vessels and restores normal blood flow so the chemotherapy can penetrate it better. And these drugs are found to be highly effective, especially when they're combined with chemotherapy. There have been many studies that have been performed, but the big one is the GOG, which stands for Gynecological Oncology Group. It's a group of surgeons and medical oncologists who are part of this, and they conduct clinical trials across the country. And in this study, 452 women were randomly assigned to chemotherapy, either with or without this drug. And patients who got this drug, bevacizumab, in addition to chemotherapy, did much better. The chance of cancer shrinkage or response rates were better, their survival was better, and patients were able to live longer. So adding this biological drug to chemotherapy has shown to improve survival. It takes time after these studies are published, it takes time for the FDA to approve these drugs. And currently this can be considered for patients with advanced cancer. Again, as I mentioned, we don't do chemotherapy or radiation if somebody has very early stage cervical cancer. Those patients are treated with surgery. But for patients with advanced metastatic cancer, this can be considered. This is a picture of a tumor with blood vessels feeding nutrients and oxygen. And after you give this drug, bevacizumab, it disrupts the formation of blood vessels. And you streamline the tumor with normal blood vessels, and this leads to basically the tumor not getting enough nutrients and oxygen, and chemotherapy doing a better job in controlling the cancer. There's some also interesting research. Again, these are not one of these. This next slide. This is not standard treatment, but this is kind of where the direction we're headed in terms of using immune-based therapy and T-cell therapy in cervical cancer treatment. And these are very small studies. And basically what happens is the patients with metastatic cervical cancer receive what's called tumor-infiltrating lymphocytes. So basically you take lymphocytes from a patient and you program these cells to fight cancer, as opposed to chemotherapy fighting these cancers. We use the patient's own immune system to fight it by programming these T cells. So this is not standard therapy, this is in clinical trials, and hopefully in the future we will have some success once we have some more data. Now, we covered ovarian cancer, cervical cancer. What I'm going to talk about next is ovarian cancer. I'll quickly talk about the incidence since this has already been covered, but there are about 22,000 new cases, and it's only 3% of cancer in women. In the lifetime risk, we talked about 1 in 72. Average age of diagnosis is about 63, and 5 to 10% of the patients can have what's called, the cancer could be familial, meaning there could be a genetic reason the patients may have inherited a gene, and Margot is going to talk about some of these genes that are responsible for cancer development. But as you can see, up to 80-90% of the patients develop cancer, they do not necessarily have a genetic basis for it. Although over time we may find more genes that we haven't quite discovered yet. So I'm going to talk about chemotherapy for ovarian cancer. Chemotherapy essentially are chemicals that are injected intravenously to stop cancer growth, and these drugs kill cancer cells or stop them from dividing. And there are many different chemotherapy drugs that are available, and I've listed some of them here. I won't have time to go through all of them. But chemotherapy can be given intravenously, but for ovarian cancer, it can also be injected into the peritoneum. It's called intraperitoneal chemotherapy, where chemotherapy it can circulate inside the abdominal cavity, and some of these cancer cells, which are on the outside of the bowel, can be effectively treated by this approach. And this approach actually is fairly useful for certain patients with certain types of ovarian cancer, and also depends on the patient's willingness to do this. And in this community, we have done a fair amount of intraperitoneal chemotherapy for ovarian cancer. In some of the smaller communities, they may not have expertise, or the surgeons who put in a port, because it does require a tube to be inserted into the abdominal cavity so the chemotherapy can be given into that. So who gets chemotherapy? It depends on the stage, right? So if the ovarian cancer is found in very early stage, let's say stage 1A, they may not need chemotherapy. But for certain patients who have, for example, high-risk cancer that's stage 1C or stage 2 or stage 3, once the surgeons have done debulking surgery, patients then come see us to discuss what's called adjuvant chemotherapy, meaning chemotherapy is given in that situation to prevent cancer from growing, because even though the surgeons have done an excellent job in removing the cancer, they can see there could be microscopic cancer cells elsewhere, and those can be treated with adjuvant chemotherapy to get rid of those cancer cells before they have a chance to grow. And the goal in that situation is to cure the patient and improve the cure rates. Even though they may have achieved a potential cure with surgery, chemotherapy can improve the cure rates. But if patients have stage 4 ovarian cancer, the situation is a little different. We still do chemotherapy, and chemotherapy still can be effective. And in fact, ovarian cancer is a very chemosensitive type of cancer that responds well to chemotherapy. But the goal in that situation is to prolong a patient's life, and also to alleviate symptoms such as buildup of fluid in the abdomen, which is called ascites. And the chemotherapy may not necessarily cure patients, but it's not uncommon for even in patients who have stage 4 cancer to live many, many years. But they just have to get different types of chemotherapy throughout the course of their lifetime. And you go from one to the next, to the next, to the next. And that can go on for years, potentially. Even though it's not curable, we can still preserve patients' quality of life, and potentially chemotherapy can be life-prolonging treatments. I've listed some chemo drugs, but we won't go through them. This is sort of a timeline in terms of what chemo drugs got approved in which year. The slide may not even be visible in the back of the room. Just remember, there's lots of chemo drugs that are available at our disposal. And what becomes very important when we choose chemotherapy is the side effects, because each of these chemotherapies have unique side effects. When we give adjuvant chemotherapy for somebody with curable cancers, let's say stage 1, sometimes stage 2 and stage 3, we kind of use a standard approach and a standard regimen. Either we give the chemo intravenously, or we can give the chemotherapy into the peritoneum or abdominal cavity. Just remember, when we give chemotherapy into the abdominal cavity, we still have to give some chemo drugs intravenously. So intravenous chemo is still part of that. And as time goes on, more and more drugs are becoming available. As I mentioned before, with cervical cancer, there's data on using these new biological drugs that can be combined with chemotherapy. In ovarian cancer, there's a fair amount of progress that has been made, and there's a lot more work that needs to be done in terms of adding biological drugs. And again, the bevacizumab, or the Avastin, is one of those drugs that has found some usefulness in this disease. It's a monoclonal antibody which stops formation of new blood vessels. But besides that, there are other biological drugs called like pazopanib, not currently approved, but it's a drug that can also work in a similar fashion by inhibiting blood supply to the cancer. And there's a new class of drugs that can be helpful in certain situations. They're called PARP inhibitors that can block repair of DNA. What happens is in patients with certain mutations like BRCA mutation, they have a defect where the cells cannot repair themselves. And these types of drugs can be pretty useful in terms of adding benefit in addition to chemotherapy. This is kind of a picture of how bevacizumab or Avastin works. On the bottom you have a cancer cell, and it relies on these two proteins called VEGF receptors. These are proteins on top of the cancer cells. And VEGF is a molecule that circulates in the blood, and it binds to that and makes the cancer cell grow and make abnormal blood vessels. So what bevacizumab does, it binds to the VEGF, and by doing so it takes away the signal and prevents the cancer cells from developing new blood vessels. But there are some other drugs that are mentioned on the right that we don't have time to get into that work on different sites along the same pathway. So as time goes on, we may see more and more drugs get approved, but the concept is still the same. These drugs work by blocking formation of abnormal blood vessels. I'm just going to talk a little bit about new advances in ovarian cancer. This is a drug, pazopanib, that I just mentioned. In this particular trial, 900 women who had surgery for ovarian cancer, who had completed chemotherapy, were randomly assigned. They were either given placebo or they were given a drug called pazopanib, and they were given this treatment for 24 months. And the study showed that if you got this drug, pazopanib, it delayed progression of ovarian cancer compared to placebo. What we've seen time and again with some of these drugs is these drugs delay the time before cancer starts to grow, but in the long run it may not necessarily change survival, or it may not change how long somebody lives. It just delays the time before somebody sees the next chemotherapy. So over time, with studies, we will see if it makes a difference in terms of making people live longer. Chemotherapy, surgery and chemotherapy, we know, has shown to make people live longer. We don't know if these drugs are just delaying the inevitable or they're making patients live longer. That remains to be seen. But it certainly buys you more time in terms of when you see the next chemotherapy. Cancer immunotherapy, again, as I mentioned before, so the new class of drugs that we talked about that block formation of blood vessels. Again, there's a lot of work being done in actually using the patient's immune system to attack the cancer. There is a lot of excitement about this particular treatment called anti-PD-1 antibody. Again, without going into too much detail, this type of drug, not the exact name, this type of drug just got approved for melanoma. This is the first drug got approved for melanoma. It's just a matter of time before it gets approval in other types of cancer. What this drug does, what happens is the cancer is kind of smart. It secretes chemicals, and it prevents patient's immune system from attacking the cancer. What these drugs do is takes that away. It basically takes the brakes off of the patient's immune system. The cancer puts brakes on the immune system. These drugs take the brakes off. So it allows the patient's immune system then to attack the cancer. So more on this later, but there's a lot of excitement about what's happening with ovarian cancer and uterine cancer for that matter. I'm going to talk a little bit about uterine cancer. Again, Dr. Pegg explained to you that most of the times it's found in early stages. And if it's found in early stage, the treatment of choice is surgery. And many of these patients may not even need any chemotherapy or radiation, but sometimes the radiation is needed afterwards. But if patients have more advanced ovarian cancer, let's say stage 3 or stage 4, then chemotherapy is utilized for treatment. In 2013, about 50,000 patients will be diagnosed with uterine cancer. It includes endometrial cancer, and a type of cancer that's less common is called uterine sarcoma. It's rare in women under age 40, and typically seen in patients age 50 or older. Lifetime risk, 1 in 38. as we talked about, early stage is more common, but advanced cancer is also seen less commonly. This has been discussed already. Sustained exposure to estrogen and rising obesity rates in this country are possibly responsible for this. In patients with intermediate risk disease, after they have surgery, they're offered radiation therapy, and for more advanced disease, chemotherapy is something that we discuss. And again, as far as chemotherapy goes, there are standard chemotherapy regimens, but other types of chemotherapy regimens can be used as well. There are clinical trials for uterine cancer. Basically, there's a clinical trial that's GOG 258 that took patients with more advanced disease, stage 3 or stage 4, and they randomly assigned patients to adjuvant chemotherapy. One of the most commonly used regimen is a regimen of carboplatin and Taxol, or for patients to get chemotherapy and radiation followed by 4 cycles of chemo. The point here is, for more advanced patients, the question is, does chemotherapy and radiation add more benefit to just giving chemotherapy alone? And this time will tell if chemoradiation is needed. Long-term effects of treatment. I'm sure people who in the audience who have undergone chemotherapy, they're well aware of some of these symptoms of chemo, such as fatigue, pain, weight gain, depression and anxiety, insomnia. Chemo brain, it's a phenomenon where people have trouble remembering things and they're not as sharp. Over time, that gets better. Again, there's a lot of research going into that. Inability to work, loss of employment, change in personal relationships. So what can you do? I mean, exercise, staying active, physical therapy, coming to cancer support community and utilizing all the resources they have is an excellent way to boost self-esteem and help improve some of the side effects of treatment. So